I forgot to click the record button on Wednesday. We're so into that lecture. So there you go. Won't be at that one. Won't be on YouTube. Okay. Today's lecture is on, as I said, Wednesday it's not a super long lecture. It's on that pharmacotherapy of inflammatory bowel disease. And on Monday, Dr. Kosnek is lecturing on asthma. And next Wednesday, you guys have a study day. And Friday is the next exam. And then we have like the last 7 or so lectures, 67 lectures, that are kind of a grab bag of subjects. Everything that we felt we needed to cover that didn't fit in with other stuff. So it might come off as a little bit random. Okay, and sometimes I tend to get off in my own little world and go down different directions and forget to stick things on Blackboard. So if I forget to put stuff on there, don't feel bad about reminding me. So study guides and what have you. Okay, that's the old reference reading. That's Goodman and Gilman. You can find the correct chapter in 2011 version. Right, inflammatory bowel disease, I covered it just a little tiny bit in the last lecture, but this is, if I ask any questions, well, I will ask questions on it, and those will be for this lecture. Okay. And so what inflammatory bowel disease is it's a bunch of related chronic inflammatory intestinal disorders, diseases, can cause people a lot of problems. The GI symptoms include, I have on the list here, pain, diarrhea, bleeding, anemia, weight loss, all kinds of things. This disorder, or these disorders really, are often associated with other disorders, things like arthritis, joint inflammation in the spinal bones, sclerosing cholangitis, which is bile duct inflammation, uveitis actually is associated with IBD, and then tissue necrosis, and erythema nodosum, which is inflammatory nodules under the skin. So a lot of those are probably have an autoimmune component to them, and it looks like inflammatory bowel disease also has a bit of an autoimmune component to it. It's classified into 2 main subtypes, ulcerative colitis and Crohn's disease. And so ulcerative colitis is characterized by the confluent mucosal inflammation of the colon. So that starts at the anal verge and then extends to varying lengths in the intestine. Whereas Crohn's disease is inflammation of any part of the GI tract. So it can occur in different places. The most common is next to the ileocecal valve. Crohn's disease is kind of it's a tough one. There'll be areas in the intestine where you can have inflammation and problems, and then other adjacent to that things can look okay, and then downstream from there there'll be other areas where there's inflammation, etc. And ultimately, the disease can lead to the development of fibrosis and fistula, things like that. So essentially, remodeling the insides of the intestines. This slide shows where the ileocecal valve is. Once again, that's where Crohn's disease is most commonly seen. So it's down in this area here, the area I have circled. So, and on this is a view of the inside of the cecum. So down here, and here's where the ileocecal valve is. It's where the small intestine comes into the cecum there. So that's where a lot of the problems with Crohn's disease occur. Just to kind of give you an idea of of what's going on inside the intestines. This is a picture of ulcerative colitis. So you see all these little ulcers around here. So you can imagine if that's your intestines, that probably doesn't feel real good. In terms of therapy, these are kind of tricky diseases to treat because there's no unique abnormality, there's no straightforward pattern to the disorders, and also the symptomology fluctuates. So you can, it'll be one of those disorders where one day or 1 week it's really bad, and next week maybe not so bad, etc. So, and people with those kind of disorders, as anybody's had one, will know it can be really frustrating, really fluctuating symptoms. The current therapy is mainly aimed at decreasing inflammation, but there's no agent out there that seems to totally achieve this, though. So the goals in pharmacotherapy basically include, as I have here, controlling acute exacerbations, so acute flare-ups of the disorder, maintaining remission, get somebody in remission, keep them there, and then also treating specific symptoms as they arise. So in terms of the differences between ulcerative colitis and Crohn's disease, they seem to have different pathogenic causes. And in Crohn's disease, there's some infiltration of lymphocytes and macrophages in the intestine, which were thought to be involved. There's also granuloma formation and submucosal fibrosis that can occur. Whereas in ulcerative colitis, we get lymphocytic and neutrophilic infiltrates. Just putting up, wanted to give you another kind of view of what sort of thing happens inside the intestine with these, or inside the GI system with these disorders. So this slide shows a piece of tissue from someone who had Crohn's disease. So here's the cecum. You can see the tissue was pink and relatively healthy, and then here's the inflamed ileum over here. Okay, the inflammatory factors that are thought to be involved in these disorders for Crohn's disease, increased interleukins, including IL-2 and IL-12. Also, there's increased interferon gamma production, increased tumor factor alpha production, and then also increased T helper 1 cell mediated inflammation. A lot of inflammatory factors involved. In ulcerative colitis, you also have the increased T helper mediated inflammation, but it's T helper 2 cells. It's thought to be more involved. And this slide simply is really here just to reinforce the point that there's T helper cell mediated inflammation in these disorders. So with the T cell 1, this is more for Crohn's disease, where you get interleukin 2, interferon gamma, TNF alpha, and leukotriene. I think that's LP for leukotriene. But then that of course is going to cause cell-mediated inflammation responses. And then over here we have the T2 cells, where you get increased interleukin 4, 5, 6, 10, 13, etc. And among other things, you'll also get a humoral response there. Essentially, overall, you have inflammation. There appears to be a genetic component to Crohn's disease. There's a protein called NOD2 that's expressed in monocytes, granulocytes, and dendritic cells and epithelial cells. And that protein is hypothesized to work quote-unquote sensing bacterial infection and dysfunction during the disease. So probably upregulated during the disease. Okay, just going to go into the general pharmacotherapy for inflammatory bowel disease. And everybody will probably be treated Methylamine is one agent that gets used. It's 5 amino salicylic acid. Um, exactly why it works, mechanisms by why it works, it's not entirely clear. Thought that methylamine might work to inhibit TNF alpha and interleukin 1 synthesis, and also inhibit the synthesis of other inflammatory mediators. It's also thought to possibly be a free radical scavenger to get rid of those radical oxygen species and lead to inflammation, that sort of thing. So methylamine is given as a prodrug, so this is the precursors here, and it comes in topical and suppository forms that are used for proctitis and distal ulcerative colitis. So obviously, if you have a topical form, you're only going to get access to so much of the areas that are disrupted. Methylamine itself has adverse effects. It occurs in quite a lot of patients, 10 to 45%, and that's related to sulfur-moiety that it has. And those include the list here like headache, nausea, fatigue, allergic reactions, etc. Also, may decrease sperm motility. So, yeah, exactly why that is, I don't know, but perhaps it's the proximity to the testes where it gets applied. This shows methylamine release sites once again. It's given as a prodrug, so and you'll give it depending on where the problem is. You give it different type of release drug. So the delayed release capsules can be released. The drug itself can be released throughout the GI system, and then you can have pH sensitive agents that are released further down the GI system, and then there's sulfasalazine and olsalazine, those precursors, those are released in the anticolon. As you probably expect, glucocorticoids can also be used to treat IBD, and these will work for some patients. There's 3 classes of responders to glucocorticoids. There's the steroid responsive people. So you can give them a glucocorticoid and they'll get a good response. There's people who are dependent on steroids, so if they, the disorder will get too bad if they don't take them. And then there's steroid unresponsive folks too. So some folks, glucocorticoids don't work. Okay, and you guys know how glucocorticoids work by now, I hope. And they can be given in enemas or suppositories for more distal cases, or given systemically, obviously. Another group of agents that get used for these disorders are immunosuppressive agents. Like the start of the lecture, just talking about a degree of the autoimmune component to IBD. These guys were initially developed for things like cancer chemotherapy. They do sometimes get used. They have very high potential for adverse effects. So obviously you're going to use them with caution. And these agents include thiopurine derivatives like mercaptopurine and azathioprine. And these guys work by impairing purine synthesis. So that's you're going to essentially screw up the DNA, RNA production, and inhibit cell synthesis. And so adverse effects with these guys, obviously there could be a lot, fever, rash, paralysis, etc. So essentially you're interfering with the genetic machinery to try and stop what's going on in the bowel. And methotrexate also gets used. Methotrexate inhibits dihydrofolate reductase, and ultimately what this does is it blocks DNA synthesis. So this stuff is, we'll cover it again. We've come across it before as well. It's also used for autoimmune diseases and dermatological disorders. So once again, with methotrexate, you're disrupting DNA synthesis. Cyclosporin, which is misspelled here, it should be cyclosporine. Is a calcineurin inhibitor. It's a potent immunomodulator that also gets used for people, who have transplants to reduce rejection symptoms. I heard Dick Cheney got a new heart, so he's on cyclosporin, right? He's not my favorite guy. This slide just emphasizes the MOA of methotrexate. So essentially what you're doing, once again, is the main thing you guys need to remember is blocking DNA synthesis. Okay. I'm not going to worry about this down here. Okay. Anti-TNF alpha therapy, tumor necrosis factor therapy, can be used for inflammatory bowel disease as well, and the drug that does this is infliximab. What that is immunoglobulin that binds and inhibits TNF alpha. As a reminder, TNF alpha is the main cytokine in mediating T helper immune cell responses. And once again, in Crohn's disease, you get this upregulation of T helper 1 cell immune responses. So this is basically an antibody that binds TNF alpha and stops that process from going on. It's also hypothesized to have other actions that might be helpful, including it potentially can cause cell lysis by causing antibody-dependent or cell-mediated cytotoxicity. In addition to using this anti-TNF therapy, so the antibodies that bind TNF alpha stop it from working, both anti-interleukin-2 and anti-integrin, their antibody therapies can be used. So with anti-IL-2 therapy, what that does is we have an antibody to interleukin-2, identifies IL-2, binds to it, stops it from working, and that stops the cell signaling that IL-2 stimulates. Anti-integrin therapy blocks the attachment of adhesion cells to endothelial membranes and stops the negative processes that occur with that as well. These guys are going to have lots of adverse effects. You need your TNF alpha and interleukin-2 and integrins to be working normally, for a completely healthy person. So just watching that, these guys can have problems, chills, fever, urticaria, and anaphylaxis. Who knows what urticaria is? Hives. You guys are on what? That's good. Okay. And then subcutaneous reactions can occur. So those are serum sickness-like reactions. This slide just shows the anti-TNF antibodies. Once again, the main point is these are antibodies that have been raised and are directed at TNF alpha or TNF alpha receptors. Sorry, they've been raised or produced. It's been postulated that IBD can be caused by an imbalance in the mucosal epithelium, gut flora, and immune responses. And to distill that down, some bacteria are thought to be pro-inflammatory, and they're thought to have a better environment in people with these disorders to do their stuff. Other bacteria can be considered anti-inflammatory. So bottom line, though, is that antibiotics can be tried to correct imbalances with the gut flora and people with IBD as well. these are mainly used as adjuncts with anti-inflammatory agents. Um, and also, they can be treated for specific Crohn's disease complications. And antibiotics can be used prophylactically, especially with somebody. A lot of the time, the final solution to things like Crohn's disease is to take out the diseased area, and when that happens, a lot of times people give an antibiotics as well, like infection that can go on, especially with the post-operatively. And these guys are most beneficial in colonic cases of Crohn's disease. And ciproflox and metronidazole are the agents that may be used. Probiotics are a mixture of putatively beneficial lyophilized bacteria. It's a therapy that's been tried. I think it's too much of the probiotics. It's debatable how much they work. But essentially, with probiotics, what you're doing is giving good bacteria to the person and hoping that has anti-inflammatory activities. And I think this is the last slide. It essentially shows the IBD, well, it shows the IBD pathogenesis or hypothesized IBD pathogenesis and the agents that are used to treat each effect or each specific issue that might be involved in the pathogenesis. So if you study this slide and know why each of these agents is used, each agent that I have circled, you should be fine. So with the antibiotics and probiotics, what you're going after is the bacteria. Okay? The antibiotics are trying to kill bacteria, the quote-unquote bad bacteria that are going to cause inflammation, etc. Probiotics, you're trying to give quote-unquote good bacteria to somebody. It's going to decrease inflammation. And then here we have the anti-interleukin-2 and TNF-alpha agents. We have antibodies for the TNF-alpha itself and TNF-alpha receptors, and then for interleukin, 12. So, and over here we have interleukin-2. Okay, and then the anti-integrins can get used. Those are aimed at stopping integrins from coming across the endothelium and causing inflammation that way. Okay, and the last slide is this is just agents used to treat IBD, and you can go over this yourself if you like. I'm not going to go over the table here. Because this is such a short lecture, I'm going to pull 2 questions resolved for this lecture. So that this upcoming test though has quite a bit of stuff on it. So maybe that will just explain a little bit. Kind of the way I rate the test this year, so this one is a little bit more heavily weighted than the other ones. And then the last one, the final is so close to it, only covers 6 questions. All right. If you have got questions or whatever, let me know. Oh, well, that reminds me. Somebody asked me about somatostatin for constipation. I don't know if I got back to that person. I don't think I did. It's the somatostatin analog octreotide. So it's not mainly, I listed it for constipation. It mainly gets used for diarrhea, actually. Remember, somatostatin is that blocks hormone secretion, in particular blocks gastrin secretion. So octreotide is actually mainly just used for diarrhea. The only reason I could find it might be used for constipation is by blocking gastrin. You're going to block the breakdown of food and things like that. So whatever gets taken into the gut then passes on into the intestines in its undigested form, and that might help with just because of the makeup of the stuff, it might help move things along in the intestine, but it is mainly for diarrhea. Okay? So, hopefully that makes sense. All right. Have a good weekend. Hopefully it will get nice out again.